Today, we're going to learn about CAR T cell therapy to help care partners understand how it works, what happens during recovery, and why care partners are so essential throughout the process. Before we get into the discussion, please remember that this program is not a substitute for seeking medical advice. Please refer to your healthcare team about what might be best for you. Well, let's meet our guest today. Joining us is Dr. Shambavi Richard. Dr. Richard, welcome. Would you please introduce yourself?
Hi, I'm Shambavi Richard. I am in the myeloma faculty at Mount Sinai. I'm Associate Professor of Medicine, and I co-direct the CAR-T and cellular therapies for myeloma at my institution.
Well, thank you so much for joining us today. We really appreciate you taking the time.
Thanks for having me.
Let's begin with the basics of CAR-T cell therapy. What is it? And maybe, actually, we could start with what CAR is short for.
So CAR stands for chimeric antigen receptor. So CAR T cell is a chimeric antigen receptor T cell therapy. What that means is T cells, which is one of the cells part of our immune system, are taken from the patient. They're expanded and activated in a manufacturing facility, and there they undergo genetic modification and to form the CAR T cells. And what's special about the CAR T cells is that they have the capacity to recognize myeloma cells and are efficient killers of the myeloma cells.
Who might this approach be right for? What determines eligibility?
So interestingly enough, today, as we speak, CAR T cells may be eligible for many different kinds of, in the phases, many different phases of the myeloma journey. When they were initially tested, as most new therapies are, they were tested on patients who had very advanced myeloma, really were not candidates or, did not have great options for any other kinds of therapy. And when they got tested in these groups of patients, they really had stellar results that far outstripped anything else that we had as options for patients in those advanced stages of myeloma. So the approval for CAR T cells as they stand today for myeloma is for advanced myeloma, who have patients who have had 4 or more lines of therapy and have had exposure to pretty much, the major 3 classes of therapies for myeloma, which includes proteasome inhibitors, IMiDs, and anti-CD38 antibody therapy. But having said that, now CAR T cells are being moved into earlier lines of therapy and are being tested in various clinical trials. And even for newly diagnosed myeloma patients to see if they are as good as autologous transplants, are they better than autologous transplants, and so on and so forth. So really, that's what I mean by saying, for now, CAR T cells are appropriate for anyone if they are candidates for clinical trials. But in terms of approved indications for CAR T therapy, those are for advanced myeloma patients who have had at least 4 lines of therapy.
Dr. Richard, what are the potential side effects or complications of CAR T cell therapy?
So there are several possible side effects with CAR T therapy. It's a little different from autologous transplants. And I bring that up just to say, because they're both cellular therapies, so are frequently compared and contrasted with autologous transplants, which we have had for about 3 decades now. So the main side effect that for after CAR T therapy is something called CRS, or cytokine release syndrome. So that happens when CAR T cells recognize the myeloma cells and kill them. A host of chemicals called cytokines are released in the body, and this can make a person feel like they have a bad case of the flu. So it may be things like fevers, chills, body pains, headaches, loss of appetite, nausea, fatigue. So these are some common, symptoms of cytokine release syndrome. But these are the milder forms. So in more severe cases of cytokine release syndrome, you can have things like drop in blood pressure, drop in oxygen levels, needing supplementation with oxygen, or in terms of drop in pressure, they may need fluid resuscitation, or sometimes even pressors, blood pressure medications that help to boost the blood pressure. So that's one major side effect. Another is something called neurotoxicity. So you can have neurological side effects from CAR T therapy, which when it occurs in the setting of CRS, that's called ICANS, or immune effector cell associated neurotoxicity syndrome. That's what that acronym stands for. And it can be, has a constellation of symptoms such as confusion, disorientation, difficulty with some common everyday tasks. The handwriting may go off, attention deficit, things like that. But then there are, in more severe forms of ICANS, you can actually have lethargy, coma, seizures, brain edema, so much more scary things. Then there's another form of toxicity called delayed neurotoxicity, which looks completely different. Now you have things like Parkinson's disease or neuropathies, either cranial nerve neuropathies or peripheral neuropathies, Guillain-Barré, which is a kind of ascending paralysis. So all of these are also possible as neurotoxic side effects from CAR T therapy. Aside from these, there is another which is called HLH, or macrophage activation syndrome, or hemophagocytic lymphohistiocytosis syndrome, wherein patients can have organ toxicity, spiking ferritin levels, new fevers, new neurotoxic symptoms, additional lab abnormalities, such as liver function test abnormalities. So these are other forms of neurotoxicity, of just general CAR T cell toxicity. Then in addition to these, you can have infections, prolonged blood count abnormalities, cytopenias as we call it, which can affect, the white cells or the platelets or anemia and things like that. So these are also possible. And then finally, things like second primary malignancies, which can happen, other malignancies that can happen that may be related to CAR T therapy. A lot of these are still being studied. We don't have a good understanding of how frequently this happens, but these are all possible side effects of CAR T therapy.
Do any of the complications have to result in hospitalization, or can patients be treated outside the hospital?
So the way things stand now, and this may be slightly different depending on the specific CAR T product, but we generally keep patients hospitalized for the first 2 weeks after the cell infusion. Most of the side effects, such as the CRS and the ICANS, tends to occur during this hospitalization phase. HLH and delayed neurotoxicities can occur while they're still in the later phases of their hospitalization, or it can occur later after they get discharged from the hospital. Infections and cytopenias, of course, can happen for a while following CAR T therapy. Once they're discharged from the hospital, we ask that they stay close to us, usually within an hour or two of the hospital, so that they can quickly come back in if there's any issues. We see them quite frequently. Once they get discharged from the hospital, I see them at a minimum of once a week, more frequently at least a couple times a week, or even 3 times a week, depending on what their blood count needs and monitoring needs are. So we have them stay close to the hospital if they are far away, and the sponsor and our social work and the insurance can work together to figure out how to help them with the hotel costs if they have to stay close to us. And that's for an additional 2 weeks after they discharge from the hospital. Following that, patients go back to their homes, but we still follow them quite frequently, depending on what their needs are in terms of possible side effects.
Mm-hmm. Dr. Richard, how is CAR T cell therapy impacting the landscape of myeloma care?
So as I'd hinted or alluded to previously, prior to CAR T cells appearing on the horizon, we had very limited options for patients who had the first several lines of therapy. So once they had been exposed to 2 proteasome inhibitors, two IMiDs, and an anti-CD38 antibody, which is the three major class of myeloma drugs. They are then called triple class exposed or penta exposed, depending on how many of these drugs they've been exposed to. We had a study called the Mammoth study this was published back in 2019, prior to the era of CAR T cells and other T cell directed therapies. And at the time, they had looked at patients who were triple class exposed and who had been exposed to daratumumab and were refractory to daratumumab as their last line of therapy. And what we saw was with any and with the next line of therapy or whatever else was available at the time for patients such as these, their expected response rate was only about 30% or so, number one. Two, their outlook was very poor, with a median progression-free survival, which means that, the amount of time that patients could go without the disease coming back of being, and that median progression-free survival was less than 6 months. And their expected even median overall survival was well under a year. So that was what the landscape looked like when CAR T cells came onto the scene. Then, with the, for instance, the CAR-T2 trials, which is, one of the approved products, which is TCell, which is what we have now, we actually saw for this same group of patients, the response rates was now 98%. Deep responses were 83%. And we now have the final readout of their median progression-free survival, which is almost 3 years. So you can see a significant difference, under 6 months median progression-free survival to 3 years. And patients were living, over 50% of the patients were living over 3 years. So that's kind of where we are at. I mean, so it was no small improvement. This considerably kind of almost reset the bar and has given a new lease of hope and life to patients who had advanced myeloma. And, one of the things we say in myeloma is, although we don't as yet say that myeloma is curable, we are working, towards that, but we are also giving options for other treatments, other research to be effective in patients just by keeping them around longer.
Have there been any recent research developments involving CAR T cell therapy that patients should know about?
Absolutely. So, so much as I have highlighted all the the hope and the optimism and the good things about this, the fact is we're still not curing people with these therapies. So we call this a plateau in the survival curve, which means that if we achieve that plateau, that means the disease is probably not coming back. And we have essentially the definition of cure. But we're not seeing that. We're still seeing a downslope in the survival curves for myeloma, which means that patients are still relapsing in spite of these excellent therapies. So there's a lot of research going on into why are patients still relapsing? Is it because, they're losing the antigen which the CAR T cells are recognizing? Is it because the CAR T cells are no longer effective, even though the antigen is still present? Is it because, there's a considerable lag time between the patients being freezed or collected, the cells being collected for the genetic modification in the lab, to the time when the patients can actually receive these cells? And that can be anywhere between 4 to 8 weeks. So during this time period, patients with advanced myeloma may not remain static with their disease. The disease is progressing, they're getting worse, they may not be candidates for these kinds of therapies. So one of the areas of research is how can we speed up this process, this manufacture process? How can we make it much more available? Because they're limited by the manufacturing facilities, their abilities to have these viral vectors, to be able to transduce these cells and genetically modify. So can we take them off of those kinds of things? Can we automate this? Can we, improve these manufacturing platforms? So a lot of different things are being tested. And then, as I'd also mentioned earlier, right now they're approved for advanced myeloma, but what if we can bring them up earlier? Are patients actually going to get cured by that? Are they going to have a much better, progression-free survival with that versus waiting until they're very advanced? So these are all many, many things that are being looked at. In addition, a lot of these CAR-T products, these approved products, all of them are all recognizing one antigen on the myeloma cell. Now their products are being looked at that are dual target antigen recognition ability. So that's another thing. So maybe if the CAR T cells are missing one of the antigens and they're not able to use that to kill the myeloma cell, maybe the other antigen can pick up the slack. So these are various things that are being looked at.
Well, now that we understand a bit more about what it is, let's walk through the process. When a patient goes through CAR-T, what happens first?
So the first step is being referred to a CAR-T physician. Right now, CAR-T therapies can only be done in certain tertiary care institutions, not even all tertiary care institutions. They have to have the ability to, to manage and process cellular therapies. So that's limited right there. So patients have to be referred to centers who actually do these CAR-T kind of therapies. Once they meet with the myeloma physician who deals with CAR-Ts as well, then the way it works in our institution is then we assess them for which is the best kind of CAR-T product the patient may be eligible for. Are they eligible for clinical trials? Do they fit the profile for clinical trial? Are the patients willing for clinical trials? If not, are they candidates for one of the commercially approved products? As I said, there are specific criteria. Patients have to have had at least 4 lines of therapy to be able to receive a commercially approved CAR-T product. If that is the case, and once the process has been explained to the patient, they have to go through all the financials, the insurance approval. These are very expensive propositions. So the insurance, goes through all of the criteria to make sure that they will approve the product. Once the insurance approves, they also go through an institutional approval process to make sure that these are, again, being done for the right patient and that they go through the institutional approval. There are several patient-specific characteristics. For instance, we want a patient who has the support structure to be able to support a therapy like this. They have to have a good performance status. They have to be relatively able to be able to handle these kinds of therapies. I went through all of those side effects that are possible. We look at their cardiac status. We look at their neurological status. We look at the pace at which their disease is escalating, because these are, again, advanced patients. So if somebody is relapsing very quickly, they may not have the time to wait to get to a slot for the pheresis and then to wait again for the manufacturing to happen. So we look at all of that. We look at their kidney function. And then finally, in terms of their psychosocial, do they have their caretakers, the support system? Where do they live? Are they able to access our center? Are they from out of state? If so, how are we going to manage during those initial months until they're stable enough to be discharged back to their referring physician? So we look at several different things. So we have multiple teams of people: social work, pharmacy, who looks at all of these different and explains the pharmaceutical aspects of all of this, our finance team, our coordinators who put all of this together. For the pheresis, we are involved with the pheresis team, and then the cell therapy lab that processes the cells, the vascular team to put in the lines required for the pheresis. So there are several groups. And then if we need to get a consultation from our expert cardiologist or neuro-oncologist, we need to have those teams involved as well.
How long does it take to know whether the treatment has been successful?
So we get a sense, depending on what their blood markers look like. We can get a sense within the first month if the patient is actually responding to the treatment or not. I generally wait for the first 3 months to do an actual formal assessment with their bone marrow and their PET scans and everything else, because right around then you kind of, they've gone through their initial acute post-CAR-T period. And so at the time of the bone marrow, we assess what it looks like. We send for a test called MRD, which is minimal residual disease, to see where they're at with that, and PET scans to look at any areas of skeletal lesions or even extramedullary disease that they may have. So I would say within the first month, we get a sense, but by 3 months, we do that first formal assessment.
Mm-hmm. You mentioned the role of the care partner, and you've talked about the recovery process and how involved it is. What do you feel is the care partner's role in helping the patient through the process?
I think much of it is, emotional and psychological support. I think that is very, very key. But in terms of actually what they can do, we do, ask that they have a caretaker available 24/7, if possible, at least for the first month or so following their CAR-T. And this is because this is when, they need a lot of support going back and forth from wherever they're residing, whether it's a hotel or whether it's their own home, because there are a lot of clinic visits during that time. We do ask that the patients don't drive for at least the first month, maybe even the first couple of months following their CAR-T, because again, they can have neurological side effects that may be somewhat subtle. Their judgment may be impaired, but they may not look that different. So a caretaker who knows them well is very useful in saying there's something weird about how Joe's acting lately or something like that. So that's very important as well, to bring them back and forth and to manage all of these. And if there's a problem in the middle of the night, they're having new fevers, they're suddenly, neurologically altered, they do need a person to be able to, handle things and bring them in and get the adequate medical support.
What questions should care partners be asking as they begin the process?
I think a good understanding of all of this. So whatever that takes for each individual person. We have patients of various different kinds who come to us, some who have researched it and really know what's going on out there, and others who are comparatively, what is this CAR-T thing? Tell us, we have no idea what this is all about. So I meet each one where they are. I go over the entire process. I touch on all the different things that we just spoke about. I talk about the logistics of it. I talk about the timing. One of the traffic jams is being able to get that initial pheresis slot to be able to even send the cells to the manufacturing. So there's a question of, managing the resources and making sure that patients are getting to their CAR-T slots in a timely manner. So a good part of it is an understanding that all of this is not something that happens overnight. There are several moving parts. There is a way and their system and a way to that all of these have to be aligned. So so I pretty much answer whatever that they have, but I think questions touching on all of this. And finally, the exact thing that you asked, how is it that they can help? What are the things that they can do to help? And I think that is hugely important as well.
Why is it so important that care partners let the care team know about any changes in the patient?
I think the earlier we know of changes, the better, we can handle these things. There is a time sensitivity to a lot of this. If issues that happen are not addressed right away, they can evolve to more severe conditions. And if they're more severe, they're, less likely to respond right away to the therapeutic maneuvers that we have. So I think that's really important. And if they are outpatient, we do bring them in for hospitalization right away. If there is anything that is the delayed forms of these side effects, can sometimes be also a little bit harder to resolve and turn around. So it's important that they come back to the hospital right away, get admitted for the workup so that we can escalate the speed at which things can be done.
Being a care partner can be overwhelming at times. Do you have any advice to help care partners as they cope with their role?
There's a lot of support groups. I really encourage them to start talking to our social workers right away. So our social workers really do get engaged in the process pretty early. There are many different kinds of support groups. There are support groups that are myeloma specific, and then support groups that within those that are offshoots for CAR-T patients. So who can people either thinking of going through a CAR-T or in the middle of it, or even post CAR-T, all the anxiety of the monitoring, and is the disease going to come back? And that can weigh heavily on the caretaker as well. So an emotionally supported caretaker and patient just makes it a lot easier for everybody, including the medical care teams, to be able to handle all of this.
We have a few questions that our community sent in prior to the program. I'd like to start with Melissa's question. Do you have any advice for handling the emotional highs and lows as well as personality changes within the relationship?
That can be a challenging one. And, as medical doctors, we tend to not be the best people to, usually. And so what I really draw on our social work and our coordinator support for that kind of thing. We have, at our institution, we have a palliative care or supportive care oncology team who help with a lot of the, symptom management or anything like that. And if it's something that actually needs more than just counseling, if they actually need medications, then we have our psychiatric, oncology groups who also help with a lot of those. So I think being prepared for any of these is important. But I think a lot can be handled just by having a good, adequate supportive care that starts right at the beginning of the process, so that, before things start getting overwhelming.
Yeah. Here's another question we received. What kind of nutrition does a patient need during this process? And how can the caregiver ensure adequate nutritional support?
So among our various teams, we have actually a nutritionist who actually meets with the patient about the time of their discharge from the hospital, and they give them, a lot of guidelines about how to handle, various dietary things. In general, going into CAR-T, a well-balanced, healthy diet is always a good thing. Maintain your diet well as much as possible. Following the CAR-T process, we do follow guidelines for what we call a neutropenic diet, wherein, well-cooked meats are preferable to anything undercooked, because that's where you can have a lot of bacteria. We advise against raw or undercooked meats of all kinds. Pasteurized foods, obviously, much better than don't go for the unpasteurized. Don't go for the soft cheeses, which tends to be unpasteurized or difficult, wherein you can have, and also in terms of nuts, prefer the roasted nuts rather than the raw nuts and things like that. So, any fruits and vegetables, we advise that they should be well washed and cleaned. We advise against the thin-skinned ones that are harder to clean. We go, prefer rather the thick-skinned fruits where you can wash it well and then peel it. So those are, have less tendency to spread diseases and bacteria and things like that. So those are some of the things that we advise. And we do give them a dietary, like a sheet, wherein they have the do's and don'ts, because it's easy to forget some of these. We prefer you don't go to delis, don't get deli meat. So if you like those kinds of meats, get the packaged form, where you can control the quality of things like that.
What about something like raw fish? Is that recommended or not?
We prefer not, raw fish, again, like smoked fish and things like that. We prefer to avoid those things, at least for the first few months after CAR-T. We generally make these, somewhat strict for the first 3 months. Post-CAR-T patients are immunosuppressed for a long time. There's no great science at the 3-month, mark, because I think at 3 months plus 1 day, you're probably still at some risk, and everybody's immune recovery is different. So patients who are immunosuppressed for a long time, I say, just try to stick to these, unless it's something that you really can't do without. but it's much better to try to maintain these guidelines for as long as possible.
Mm-hmm. Another audience member wants to know, what is the difference between CAR-T and bispecific antibody treatment?
Oh, good one. So as I mentioned, with the CAR-Ts, the T cells that are taken from the patient is actually genetically modified. So these are kind of souped up T cells, if you want to put it that way, because one, they efficiently recognize the myeloma cells, and two, they are efficient killers of the myeloma cells, which are the two main jobs of your T cells. With a bispecific antibody, this is an off-the-shelf thing. So this is not manufactured specifically for the patient. And then it's a drug. And the drug has two receptors. One recognizes the myeloma cell, and the other recognizes the patient's own T cells. So these are unmodified T cells that are just floating around. And they bring the patient's T cells to the myeloma cell to kill it. So that's the difference. It's an off-the-shelf product versus a manufactured. The T cells are your own. They're not manufactured in any way, but otherwise they're kind of similar in that they're both T cell directed killing mechanisms, and they recognize the myeloma cell.
Okay. Thank you for that. Thoughtful answers, Dr. Richard. We appreciate it. Before we end the program, I'd like to get your final thoughts. What message would you like to leave the audience with?
I want to leave a message of hope. I want to leave a message that there is so much research going on, and we couldn't do any of these without the involvement of patients and their caregivers. And that's how we have moved the field forward to this extent. And that's how we continue to move the field forward. There's a lot of reason to hope. And the holy grail, of course, is cure. And that's what, the entire myeloma community is working toward, getting to that goal one day. So I want to thank the patients and the caregivers for helping to move this. So helping themselves and helping, others. So.
Well, Dr. Richard, thank you so much for taking the time to join us today.
Thank you for having me.
And thank you to all of our partners. To access tools to help you become a proactive care partner, visit powerfulpatients.org. I'm Catherine Banwell. Thanks for being with us.